Good night to you all, the distinguished dignitaries and the great members of this association. My name is Additional Taufik Aide Additional, an intern pharmacist at Federal Medical Center, Owo. Tonight, I will be presenting on the topic, as it has mentioned by our moderator, venous thromboembolism, commonly known as VTE. It is an important it's an important cause of preventable morbidity, mortality among hospitalized patients. VTE includes deep vein thrombosis and pulmonary embolism. But by the end of this presentation, we should be able to understand the pathophysiology of VTE, identify the risk factors, recognize DVT and pulmonary embolism, discuss about the diagnosis, and as well as the management and the prevention strategies. What is venous thromboembolism? VTE is the formation of blood clot within the venous system, which include deep vein thrombosis and pulmonary embolism. Why is it important? It is important because it is the major cause of preventable hospital death, and also it is the third most common cardiovascular disease. The epidemiology of VTE. Globally, VTE affects 1 to 2 persons per 1,000 annually, and its incidence increases with age, especially among the hospitalized, particularly among the hospitalized patients. And if the pulmonary embolism left untreated, it could result into sudden death. Definition of DVT: deep vein thrombosis. As I've mentioned earlier, VTE includes DVT and PE. So DVT thrombosis, deep vein thrombosis, which is DVT, it is the formation of blood clot within the deep vein, usually in the lower extremities, the lower limbs, such as the veins of the pelvic area, known as the iliac vein, the femoral vein in the thigh, the popliteal vein at the back of the knee joints, the calf veins in the veins in the calf muscle. While pulmonary embolism occurs when the clot breaks off and lodges into the pulmonary circulation, obstructing the flow of blood and lodges into the pulmonary arteries, obstructing the flow of blood into the pulmonary circulation, thereby causing pulmonary embolism. Virtuous triad: pathogenesis of venous thromboembolism is explained by virtuous triad, and the mechanisms are 3. First one is the venostasis. The venostasis is the sluggish or slow circulation of slow circulation of blood within the vein, causing the accumulation of activated clotting factors, resulting into thrombus formulation, which commonly associated with the prolonged bed rest, immobility, long distance travel. The second mechanism is the endothelial injury, is the damage to the lining vessels, which are associated with the surgery or trauma, especially surgery involving the lower extremities, and as well as the central venous catheter. Hypercoagulability mechanism. This is the abnormal tendency of the blood to clot more easily than normal. These are associated with malignancy, some type of cancer, such as, for example, the cancer of the pancreas, and as well as in pregnancy. Hormonal therapy as well is associated with the hypercoagulability and inherited thrombophilia. Risk factors of VTE. Risk factors of VTE can either be patient-related risk factors or hospital-related risk factors. However, the most common risk factors of VTE are prolonged immobility and some surgery as well, surgery involving the lower extremities. Obesity is an independent risk factors which causes the thrombotic state. And also smoking. It has been revealed that cigarettes contain some particles that can cause damage to the lining vessel, thereby risking VTE. Pathophysiology of VTE: a clot formed within a deep vein, enlarged and may detach. So the part of the embolus travels into the inferior vena cava and the right side of the artery, then eventually into the pulmonary artery, causing the pulmonary embolism. Deep vein thrombosis. Deep vein thrombosis signs and symptoms. Patients with the DVT often present with unilateral leg swelling, redness, warmth, and tenderness in the area, while patients with pulmonary embolism often present with sudden shortness of breath, chest pain, which is angina, dyspnea, tachycardia, sometimes hemoptysis, the coughing up of blood, phlegm, or mucus. Severe cases, so in severe cases, it can lead to hypotension, the cardiogenic shock, and suddenly it could lead to death. Complication of VTE. One of the major complications of VTE is the post-thrombotic syndrome. The post-thrombotic syndrome occurs when the DVT, that is deep venous thrombosis, damage the vein valves, resulting into the pools of blood in the legs, resulting in pools of blood in the leg, causing chronic inflammation and tissue damage. The complication of VTE also can cause the inability, or can lead to the inability of the vein to flow back of deoxygenated blood properly into the heart. While the other complication also includes, it can increase the pressure on the pulmonary artery, subsequently which will lead to the failure of the right ventricles and suddenly lead to death. Risk assessment for VTE. The risk assessment should be done immediately. This assessment of VTE should be done on admission. The use of some clinical tools, such as the Padua prediction score and such as the IMPROVE score, helps to identify patients that require thrombophylaxis. For example, on the Padua score, there are some criteria that are scored. So the sum up of this criteria, if it's greater or equals to 4, it means the patient is on high risk of VTE. Diagnosis of DVT begins with diagnosis of DVT. Diagnosis of deep vein thrombosis begins with clinical assessment and well score. Also, there are some laboratory tests, such as D-dimer, which is a blood test that is used to measure the protein fragments after blood clot dissolves. After blood clot dissolves, they support also the diagnosis of DVT. The first line image modality for diagnosis of DVT is the compression duplex ultrasonography. In diagnosis of PE, of pulmonary embolism, clinical probability is assessed using Wells or Geneva score. The gold standard image investigation in pulmonary embolism is CT pulmonary angiography. These are used to detect the clot in the pulmonary artery. We can see here is a sample of here is a sample of Geneva revised score, the first one, whereby the variables are scored. As you can see, we have several variables that are scored. So if the sum up of this score falls between 0 to 3, it indicates that there's a low probability. If it's 4 to 10, indicate that it's an intermediate, and if it's 11 or above, indicate that it's high probability. While the table below also is an example of a Wells criteria score that I use that serve as a prediction for the diagnosis of pulmonary embolism. It is very important to know that all these clinical tools, the Padua score, the Well score, or the Geneva score, they are used for prediction. They are not meant to finalize the diagnosis of VTE. Classification of pulmonary embolism. Pulmonary embolism can be classified into massive, submassive, and low-risk pulmonary embolism, depend on their hemodynamic stability and the right ventriculation function. Prevention of VTE. Prevention is the key because VTE events are preventable. They can be avoided. They are avoidable. So the prevention strategies includes the primary prevention of the blood clots and the secondary prevention, primary prevention of the blood clot and the secondary prevention of complications and recurrence. Now, moving on to the thromboprophylaxis. Thromboprophylaxis are measures that are used to prevent VTE in high-risk patients. They also aim to reduce DVT occurrence and prevent pulmonary embolism. Looking into the pharmacological thromboprophylaxis, we have the unfractionated heparin, which commonly administered as 5,000 units subcutaneous every 8 to 12 hours. The duration of the therapy depends on the clinical situation of the patient. It has the advantage of rapid onset, low cost. They are easily reversible as well. However, it has a major disadvantage, which is heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is an immune-mediated adverse reaction on heparin when the antibodies IgG formed against the complex heparin and the platelet factors, leading to causing the platelet fails by more than 50% of the baseline. So it is very important when after the administration of the unfractionated heparin, the patient has to be under serious monitoring to avoid the risk of HIT. While low molecular weight heparin, such as dalteparin, tizaparin, nadroparin, and bamiparin, luvaparin, particularly enoxaparin, they provides predictable anticoagulants and require less monitoring, lower risk of heparin requires. The disadvantage or the demerit of enoxaparin is that they are quite more expensive, and it accumulates in patients with renal impairment. So it's contraindicated in a patient that has a renal impairment. Direct oral anticoagulants, such as the apixaban, the rivaroxaban, dabitragaban, dabigatran, egdozaban, etc., are commonly used because of their conveniences and effectiveness. They have the advantage of fixed dosing, no routine INR monitoring, and fewer food interactions. What I've mentioned above from the thromboprophylaxis, they can also serve as the pharmacotherapy. However, there will be change, or there will be an increase in their dose and the duration of the therapy. While the mechanical thromboprophylaxis are the non-pharmacotherapy that are used in managing VTE. So for the patient that are contraindicated to anticoagulants, so mechanical thromboprophylaxis could be an option. For example, we have the graduated compression stockings, intermittent pneumatic compression, and venous foot pumps apply greatest pressure on the legs, allowing the proper flow of blood from the veins to the heart. So their benefits that the benefits includes no systemic bleeding risk, and they are effective as adjunct therapy for patients that are not contraindicated. It means VTE patients that are not contraindicated to the primary the primary pharmacotherapy or the primary therapy for VTE can combine both mechanical thromboprophylaxis and the primary therapy. So treatment goals in VTE. The treatment goals of VTE are prevent clot extension, prevent recurrence, prevent pulmonary embolism, reduce mortality, and preserve venous function. Initial treatment of DVT and pulmonary embolism are anticoagulants. The anticoagulants are the primary pharmacotherapy for treatment of DVT and PE. However, if they are using as prophylaxis that I've mentioned above, they have a reduced or a lower dose and lower duration of therapy. But if they are using as prevention, they have an increased dose and increased duration of therapy, such as unfractionated heparin. We have the low molecular weight heparin, the fondaparinux, which is a synthetic anticoagulant, and the direct oral anticoagulant that I've mentioned above, such as the apixaban, rivaroxaban. So the treatment of DVT should start immediately after diagnosis confirmed to avoid the complication of pulmonary embolism. In long-term coagulations, in long-term anticoagulation, long-term therapy may involve warfarin with INR 2.0 to 3.0. It is very important to know that warfarin should not be given solely, or it has to be in the combination form with oral anticoagulants such as apixaban and rivaroxaban. So thrombolytic therapy, in case of massive pulmonary embolism, some clot-busting agents such as the actiplase, streptokinase, and urokinase are used to rapidly dissolve the blood clots. May use to rapidly dissolve the blood clots, and the patient has to be under a serious monitoring because they have the risk of major bleeding, and intracranial hemorrhage. Another type of non-pharmacotherapy device for the management of VTE is inferior vena cava filter. Inferior vena cava filter are reserved for patients who cannot receive anticoagulant or experience recurrence of VTE despite adequate therapy. So the filter trap the clot in the inferior vena cava before traveling into the pulmonary artery, and therefore prevent pulmonary embolism. Surgical catheter-based interventions. Some advanced interventions may, such as catheter-directed thrombolysis, the mechanical thrombectomy, surgical embolectomy, may require in selective high-risk patients. Especially patients that have this patient with the indication of massive pulmonary embolism, failed thrombolysis, or contraindication to thrombolytic therapy. The role of the pharmacist in management of VTE. There is no doubt that the pharmacist play a key and a major role in the management of VTE through the risk assessment, selection of right prophylaxis, dose adjustment, monitoring, anticoagulant, prevention of medication errors, patient counseling as well. Now, moving on to the patient education. Patient education is not only, or should not be the only responsibility of the pharmacist, rather the responsibility of other healthcare workers. It is the responsibility of other healthcare workers and the pharmacists to educate the patient to take their prescribed medication regularly, and as well to adhere to the and as well to avoid prolonged immobility, maintain adequate hydration, recognize symptoms of DVT and PE, follow up for appointment, and ultimately they should report signs of bleeding immediately. Here is the summary, and then in conclusion, it is the treating VTE is the responsibility of the pharmacist and other healthcare professional through the early risk assessments, right prophylaxis, right thromboprophylaxis, and effective patient education. We can significantly reduce VTE complication and prevent death. Thank you.
Thank you very much. Thank you very much, Pharmacist Additional, for this interesting and educative presentation you just delivered. So at this time, we will want to, if you have a question or comment or contribution to make, just indicate by raising your hands, and then you will be given the opportunity to talk. So anybody having a question or comment to make regarding this presentation, simply indicate by raising your hands and go ahead with your question. Okay, so I can see your hands, Pharmacist Moma. You can go ahead with your question. Unmute and go ahead with your question, please.
Thank you very much, Fan Martins, and I appreciate you, our speaker for today. There is a place I'm not so clear about. I think maybe it was a mistake. I don't know. When we are talking about complications of VTE, he wrote complications of DVT, said some things, and wrote again complications of DVT. So I want to just be clarified. Did you mean to write complications of PE the second time around? Because I was being thrown in and out of the call.
Okay.
You can get onto the page. Complications of. Yes, here. So this second, the second part of it, did you mean to write PE?
It's PE. It should be PE. That's a typographic error, man. Sorry. Yeah.
That is all. That is all. Thank you.
You're welcome.
Okay, thank you for your question. And I will call on Pharmacist Ebere. I saw your hands up also. Pharmacist Ebere, Emila.
Okay. Yeah. Thank you, presenter. I sincerely appreciate you so much coming from an intern pharmacist. You know, I can see you're young and upcoming, so it's very, very commendable. Thank you so much. Well done. My own comments or question is, please, which category of patients need to be assessed for this whether deep vein or pulmonary thrombosis, like in the hospital, or which patients, or do we assess any patient that comes? Yeah. Then that's one. Then the second one, I saw one of the complications as hemoptysis. Please, but I don't know, please, can you go through the pathophysiology that leads to that hemoptysis as part of the complications? Thank you so much.
You're welcome. And I appreciate your comments. If I get your first question right, you ask about which category of patient need to assess on VTE in hospital.
Yes.
As I've mentioned, one of the Yeah, as I've mentioned earlier during my presentation, that VTE is the cause of most of preventable morbidity and mortality in hospitalized patients. And one of the risk factors that I made more emphasis on during the presentation is that prolonged immobility. So, firstly, for the inpatient has to be greatly monitored. I mean, like patients that are administered patients has to be assessed, because these are the patients that probably they have a limited restriction on of movement. So, and also all adult patients administered to the hospital should be assessed for their risk of VTE and bleeding as soon as possible after admission. So the assessment should be done on admission or after the admission. So this includes the medical inpatients, surgical patients, trauma patients, and patients with reduced mobility. Now, I don't know whether this answers some of your questions.
Yes.
Yeah. Going on to the second question, you asked about the pathophysiology that leads to hemoptysis. Hemoptysis is the coughing up of blood originating from the lower respiratory tract. So the pathophysiology involves bleeding from blood vessels within the lungs or airways, which allows the blood to enter the bronchial tree and be coughed out. So the mechanism leading to the hemoptysis is, one of the mechanisms is inflammation and infection. Maybe inflammation, the condition of such as pneumonia or tuberculosis causes inflammation, damage to the airway, and as well as some bronchial artery hypertrophy and increased vascularity. So what I can say is that the pathophysiology that is leading to this inflammation and infection, erosion of blood vessels, and the bronchial artery hypertrophy, increased vascularity. It means the hemoptysis can also cause some damage to the lining vessel, or as a result of damage to the lining vessel can result into hemoptysis.
Thank you for the explanation.
Okay. Thank you very much for the answers. I will call on Pharmacist Olabode. I can see your hands up. Olabode Ogudemiyo. Sorry if I didn't make sure I pronounce your name well. You can go ahead with your comments or question.
Yes, thank you very much. There is no offense about the pronunciation of my name. Okay. It's all correct.
Thank you.
Yes. My area of concern had actually been sorted out. That was the issue raised by Dr. Moma about the complication. So that has been sorted out. Well, I think the other thing I need to do is just to appreciate the presenter. He has done very well, and I want to give kudos to him. And one could see that he had a mastery of the topic. He has done very well, and I'm proud of him. So thank you very much.
Thank you, sir.
Thank you very much for your comments. So I will call on Pharmacist Pemi for your comments or questions. Pharmacist Pemi.
Thank you very much, moderator. And I would like to thank the presenter for the insightful and well-delivered presentation. And my question is at regards to antiplatelet drugs. In the management of venous thromboembolism, do antiplatelet drugs like clopidogrel and aspirin have any role to play in the management? That's my question.
Okay. Thank you, Pharmacist Paloma. I would say no, because VTE that include the deep vein thrombosis and pulmonary embolism is predominantly a fibrin-rich red clot formed due to the activation of coagulation cascade and the venous status. So therefore, the cornerstone of the treatment of anticoagulation is not an antiplatelet. So those are anticoagulation is not an antiplatelet. They are predominantly cascade. So I don't know. Pharmacist,
Okay, thank you very much.
Okay, thank you very much. So, pharmacist Mercy, you can go ahead with your comment or question. Pharmacist Mercy.
Okay, sir. Thank you so much, Pharmacist Taufik, for this wonderful presentation. Please, my question is, which anticoagulant is safer in pregnant or breastfeeding women in the treatment of VTE?
sorry, can you please come up again?
Okay, I said,
sorry, I cannot hear you well.
Thank you. I said, which anticoagulant is safer in pregnant and breastfeeding women in the treatment of VTE?
So your voice is breaking.
Okay, can you hear me now?
Yes, I can hear you clearly.
Thank you. I said, thank you so much for the wonderful presentation. Then the question is, which anticoagulant is safer in pregnant and breastfeeding women in the treatment of VTE?
Okay. You're asking about the anticoagulant that is safer in pregnant and breastfeeding women. Low molecular heparin and unfractionated heparins are the preferred anticoagulants because they do not cross the placenta compared to the warfarin which crosses through the placenta. For this reason, they do not affect the fetus. So low molecular weight heparin and unfractionated heparins are preferable and are the safest in pregnant or breastfeeding women. I hope that answers your question.
Yes, thank you so much.
Okay, thank you very much. I'll call on Farm Afsa for your comments or questions.
Thank you very much, moderator. And thank you, Pharmacist Taufik Additional, for the wonderful presentation on VTE. I just want to make some slight contribution as regards patients that should be screened for VTE. Of course, you were very, very correct. But I just want to emphasize that in terms of the surgical patients, it is very, very vital to screen patients that have orthopedic surgery, because I work in the orthopedic hospital. So patients that are going to have hip replacement surgeries, knee replacement surgeries, it is very, very important and compulsory to screen them, as well as some, of course, other surgeries, like the abdominal surgeries and all of that. So that's just my little contribution to the presentation. Thank you.
Thank you so much.
Thank you very much for that contribution. I can't see more hands. I just want to also share this, my personal experience in the world. In the world, I work with the geriatrics multidisciplinary team, and there we do a lot of prophylaxis and treatment of VTE. So not only for the presenter and general as also, when more than one anticoagulant is being used at the same time on the patient, we know the risk that is involved. Are there instances where that can be allowed, particularly with respect to what is called bridging overlap? My checks that I've done says that, for instance, enoxaparin and apixaban, this particular patient could no longer afford enoxaparin due to price, and then she was to be transferred from enoxaparin to apixaban, and the doctor left enoxaparin for some days because of what he described as the time it will take for the effect of apixaban to pick up. So, and that was the reason for leaving the two of appropriate. Is there any bridging overlap when switching from one anticoagulant to another? And which anticoagulant does this affect?
So your voice is breaking. I don't know. It's my internet.
Okay, let me come back again. What I was saying is that issue of bridging overlap when switching from
I can't
one
hear you
anticoagulant.
clearly. Actually, I don't know. Yeah.
Okay, hello, can you hear me better now? Can you hear me better? Hello. Okay, let me
We
welcome.
can hear you. Me, I can hear you.
We can hear you.
I
what
think
I
it's
was-
your own network.
Okay, what I'm saying, because I had to add this conversation with the doctor when he was trying to defend the fact that the patient was to be switched from enoxaparin to apixaban oral for the reason of cost, and the two of them were still going on for at least 4 to 48 hours, and his own defense was that their protocol is to leave both to run for some 2 hours so that the apixaban will begin to peak get to peak effect before withdrawing the previous one. So, but my checks show that there is no need for that bridge overlap. So, does any of us have any explanation to support that treatment protocol? That's just my question.
Can I talk?
Yes, you can go ahead, please.
All right. Good evening, dear colleagues. It's exactly what I wanted to ask, because when he was talking, he told us that warfarin should be given with DOA. Example, apixaban. The presenter, am I right?
Presenter, can you hear?
I guess he's having network issues.
Okay.
From your question, yes, we do bridge anticoagulation medication. Okay, especially when we start with warfarin first. You know, warfarin takes up to 3 to 5 days to reach therapeutic. So once a patient is on warfarin, the protocol is that you must bridge with heparin or enoxaparin. And while you're bridging, you're using the two, you continue to monitor the patient INR. Once it reaches therapeutic, that's 2, you can now withdraw enoxaparin or the heparin and then continue only with warfarin. Okay, so that's the protocol. But now you asked about apixaban and enoxaparin.
Yes, ma'am.
Okay, the bottom line is your patient INR. Okay.
Okay.
You must have to monitor your patient protein profile. Once the INR is not as good, okay, if you remove the other one, you change the half-life. So all those things will now give you an understanding that yes, let us not just withdraw this one and add the other one, and the half-life too. So it's possible that you can do that within a day or two. But you must have to know your patient INR, the protein profile. Because if the INR is good, adding the two will expose that patient to be at risk of bleeding. So that's the bottom line. But basically, for warfarin, you must bridge up to 3 to 5 days until INR reaches therapeutic. I have not really seen where apixaban is being bridged with enoxaparin. Okay, but it cannot rule it out. But the most important thing is to check the patient's protein profile status. If it's as good, there's no need. Because I know it doesn't take apixaban days to reach therapeutic, unlike that of warfarin. So there may not be reason, but the bottom line is to monitor your patient causing suicide rate. Then you can see a reason why it should be there for a day or two. In my center, we don't add the two, except if the warfarin then we bleach. I have other observation or contribution.
Okay.
Another parent should be is weight based. I didn't hear him mention it. You don't just give maybe they always prescribe 40 IU subcutaneous. You must have to check your patient's weight and dose it based on the weight. Okay? And drug interaction is very, very crucial in this anticoagulation, especially that of warfarin. And another thing, as pharmacists, we must keep an eye on our patient INR and kidney function, especially when you're using DOA, that's a Bigabam, Dabigatran. You must have to keep your eye on your patient's serum creatinine. Once there's a compromised serum creatinine, then there needs to be renally dosing arrangements. So, and nowadays we always see DOA, Dabigatran at Bigabam, fine. So there's no need to monitor at that of warfarin, but we must have to consider our patient's kidney function as we are dosing them with those medications. For antiplatelets cannot even do much for us for this VTE or so. But we still advise elderly patients, especially long distance traveling, they can take aspirin, low dose aspirin. It helps. It helps. Okay? But once there is VTE, you don't need it. It must be anticoagulation. Must. Okay? Then combining the two, there is a scenario where we combine the two. You can see anticoagulation, see antiplatelet at the same time, depending the patient's issue. It happens. But we don't use it to treat VTE. We don't. Okay, so then as we are dosing our patients with anticoagulation, we must still know how to manage heat, that's heparin-induced thrombocytopenia and thrombocytopenia too. It can be only thrombocytopenia, but most of the time it has been induced by heparin use. So as pharmacists, we should be able to monitor our patients as they're taking those anticoagulations, to know when to, because once there is heat, so use heparin or enoxaparin is contraindicated. And we should help our patient by keeping the antidote of those medications. Like if it's heparin, we use potassium sulfate. If it's dabigatran, that's usable. But most centers don't have it. So as we should try to keep those antidotes at hand, because we do see such issues. So if there's thrombocytopenia, we should bring out antidotes so that our patient will get better. This is a very good topic, which I know that we must have to work on again on it, to explain so many things that is here. I want to, on this note, thank our dear presenter. Wow, you see that you're an intern pharmacist with all this knowledge, with MFAM already. Wow, thank you so much. We appreciate you. That means
you're welcome, and thank you so much for the contribution.
You are going to go far with this knowledge. How you answer questions marvelous, because you have real insight of this topic. Thank you. I know that sky is your starting point. I want to on this note, sorry I'm talking too much. I may not talk again. I want to thank my boss who's here on this call, Pharmacist Dr. Waneka Benematoma. I'm happy to see you. My dear IPC, Pharmacist Ogunjemio, thank you so much. My professor is here too, Dr. Motola, and Associate Professor Ebere Ayog. Wow, IPC again is here. But thank you so much for joining us. Dr. Fumilayo, thank you, ma. You always with us. Just want to appreciate all of you. Our dear Mama, wonderful education committee chairman. I bless all of you may all the Holy Ghost, the Lord will serve, bless all of you for joining us tonight. I promise that we're going to go deeper into this topic because it's very, very important for our own protection. Thank you so much.
Thank you very much,
Thank you so much.
able chairman. Thank you for the words of contribution you've made, particularly the way you answered the question I raised. We are very glad to have you in this meeting this evening. Thank you very much. I must also apologize. I'm new. I couldn't recognize most of the dignitaries here. So I believe that with time, I will get used to everybody. So I want to thank the presenter once again. It's amazing that an Indian pharmacist could deliver this words of understanding on the topic that she presented on, and you were able to handle the questions that were coming from different directions. Thank you once again. The sky is your limit, is your starting point, as has been rightly said. So thank you everybody once again for making it to this meeting. Our time as we're just about the time we're supposed to end this meeting. So I'll be handing over to pharmacist IV Moma to give us a closing remark and closing prayer. Pharmacist Moma. Pharmacist Moma, please.
Can you hear me?
Yes, we can hear you.
Okay, thank you very much, Effa Martins, for accepting this responsibility at such a very short notice. And my intent too, I appreciate you for, the length of the depth of work you did to make this a success. And I appreciate everybody that are here on the call, and they encourage us to always make good use of this opportunity to attend the meetings and take one or two to enhance your practice. So on this note, I just want to say a short prayer so that we can retire after a very busy day. In Jesus' name.
Amen.
In the name of Jesus, we appreciate you, Father, for bringing us together so that we can learn one or two at this time. We appreciate you that we didn't have any cause to to sorrow or to mourn. We say, oh Lord, as we want to retire, that you be with us. We wake up to a brand new day again to give glory to your name. In Jesus' name I've prayed. Amen. So thank you all. Thank you everyone that's
Good night.
Thank
Pleasant
you very
weekend.
good night, everybody.
Good night, everybody.
Into present go show people like me mo gbo yan kan lọ sílẹ̀ pé that's one of the things if I'm former married pé mo be àwọn internal yẹn lọ́kàn fẹ́ dominate everything normally show that nípa ẹ máa ń ṣe meeting wa tá bá fi Christian prayer bẹ̀rẹ̀ àfi music parí tá bá fi music bẹ̀rẹ̀ wọn.
Sleep. I'm about Femi go and sleep.